We're going to start with EMS Medicine Live. So this is our September conference. Sorry about August. The end of school rush and end of summer holidays kind of crushed us, and we didn't have time to get one put together, and none of us were available to host one. So we just kind of called it off and came back in September with the next quarter scheduled out. So we're doing September now. This is what upstate New York looks like. Be covered in snow in about 2 weeks. But for the time being, we're all enjoying apple picking and the good weather we have here in New York. So obviously EMS Medicine Live, our goal is to create content for the average EMS physician and for EMS fellows across the country, either as information sharing or as board preparation. We've done both in the past few months. This is also a way to see EMS physicians from across the country who's taken part in this. And over time, I'd like to get you all involved to get your experiences, your lessons learned, and your skills involved in this conference. I do want to share real quick some results of a survey we sent out a couple weeks ago. We sent out a conference to all fellowship directors across the country and asked just a few questions. Just less than half have seen EML in the past 10 months or so. Majority who have not seen it have schedule conflicts, which is not too surprising. We can't make our schedule fit for everyone. There were two, one forgot and one wasn't aware. I'm not sure how that happened, but we'll find that person and make them aware. We do have 10 new fellowships who want to be a part of this. They've self-identified themselves, and we'll try to get them involved soon for teaching and being involved. We did ask what kind of content they wanted, or what kind of content the directors thought we should be putting on, and the overall lesson is they're looking for less common topics or topics that other fellowship sites can't teach. Tactical, air medical, international, wilderness, mobile integrated healthcare, and maybe some hot topics like we're doing next month, things that are pertinent to EMS physicians and are new in the literature or new across the country. And the last question we asked was the time. We had a wide range of time responses when we should be having this conference. The overwhelming majority was Tuesdays at 1, Tuesdays at 4, and Mondays at 1. I think the afternoons are popular for the West Coast, Central time zones, and then Monday, Tuesday, and even Thursday at 4, which was surprising, came up. I know for myself and Derek, we can't do Thursday at 4, so we'll look at these other times and see what works out. For the programs who did say they want to be participating in this, I think I'll reach out to them and we'll find a time amongst ourselves. We might just keep the Tuesdays at 1, but we'll try to find a better time if one exists. If you have a time you prefer, go ahead and email us or me directly. All right, so getting back to Zoom. So as usual, Zoom conference, everyone's gonna be muted. There's just too much background noise otherwise. If you do have questions, actually I don't have my laptop with me. You can message Seth Dukes, he's my fellow, or Derek Cooney, he's gonna be here for about half an hour or half of this roughly. Or you can raise your hand virtually, and we'll look for that. Since my computer screen is going to be controlled by Jeremy, I can't respond directly. We are going to ask people not to record this session. There is some patient information and some content we don't want distributed across to everyone. After we finish this conference, we'll edit some things out, and with Jeremy's permission, we'll post that online. So we may cut a couple of things out, but the vast majority of the content will still be available. And questions at the end, unmute yourself at the end and ask whatever you have, or just message us and we'll try to do it at the end as well. So today we're lucky we have Jeremy Cushman from the University of Rochester. I was fortunate enough to see his brief talk on this topic, 3 years ago, I think, somewhere around then at ASP. And he has now a longer 1 hour or close to 1 hour session on this. And it's a good topic. I really think most EMS physicians and EM folks who go in the field should watch. There's lots of lessons learned, and it's a good topic for all of us to watch. So with that, I'm going to mute myself, Jeremy, and hand it over to you, I think.
All right. Thank you, Christian.
Let me just mute my...
Thank you, everybody, for being here. Again, this I learned a lot in this relatively unique incident, and as much as I can try to share, I will do so. So I certainly value questions and comments towards the end of this. The disclaimer is that Christian has been kind enough to edit a few things on here, because there are a few things that are patient-specific things, including a video that you'll see, that out of deference for the family and an ongoing civil litigation that I can't have out in the wilderness of Ethernet. The unique thing about this event is, as I was telling Christian before we started, law enforcement, this whole event took place over about four and a half hours, and there were both law enforcement and fire department photographers at this whole thing. So there's about 800 photos of this entire event that allow for a great pictorial representation of what happened. So if I can figure out, all right. Aha, now we're moving. All right, so here's the deal. I believe it was a Wednesday. This is now 4 years ago, about 1436 hours. The Rochester Fire Department was dispatched for a crane toppled over with a person trapped, possible injuries. 6 minutes later, companies were calling out on scene. Took a few more minutes for everybody to determine the scope, and then about 1456 hours, the deputy chief had requested myself to the scene. Like many of you, we have field response capabilities that we do, and I was fortunately just wrapping up an ED shift, so skedaddled out of there quite quickly. Christian, this is not moving. Oh, maybe it is. There we go. So where are we? Well, the Genesee River goes through the center of Rochester, flows north into Lake Ontario, and in the center of the screen is one of 3 falls. This is what's called Middle Falls. Not surprisingly, there's an upper and a lower falls. And they were doing some construction on this spillway as part of an enhancement program. The street to the lower right corner is Brewer Street, which is how the incident really got its name. Initial companies arrived to see this. This is obviously a crane that should not be upside down partially in the river. And really what this crane was doing is in the center of your screen, you see these triangular concrete abutments, and what it was doing is it was leapfrogging these concrete abutments to move the crane from the north side to the south side to be able to do some additional construction. And then something obviously went terribly awry, and that this is again another picture of the crane and its rather precarious position at the time. So you wonder how this happens. This is the video surveillance of the crane as it was leapfrogging. Obviously, there was an issue. So our victim was operating that and was essentially partially ejected. Now, we didn't even know that this video existed until about 3-4 hours into the incident. Not that it would have changed any of our impacts, but it's a 30-ton crane, and it flipped over. The flow of the Genesee River, I'm going to go back up here a second. This is the last of the technical glitches, I promise, folks. So this is really how we see the crane pretty initially, with our initial responders who arrived to find a conscious and oriented victim, who you can see part of his legs in the center of the screen, in the center, right underneath the crane itself. So he was conscious, he was oriented, he was able to answer questions, but he was pinned underneath this crane. So certainly it was a somewhat unique environment. We talk about working in a fishbowl in the emergency department and everybody watching. Well, this is really the ultimate fishbowl because the scene, the crane is actually behind you from where the picture is taken. And then all of the coworkers are up along the ridge of the dam. That big door right there is holding the Genesee River back, which is always a little disconcerting. So we had a few different challenges here. We had a movable gate that obviously is part of the spillway. The Genesee River can be modified in terms of flow by Rochester Gas and Electric. And so they could very quickly shut down, if you will, the flow down the river. But of course, it had rained a whole bunch the previous couple of days, so we only had theoretically about 3 hours of time that they could hold the water flow back until we had spillage that would create some hazards. Again, this is just more situational awareness, but it puts a certain time limitation, because one of the advantages of working in the Genesee River gorge is that we can drop the flow rate tremendously, which adds a significant margin of safety. The other challenge that we had was that it's slippery. It was at a slope. The crane was at a slope, and one of the reasons that this incident took as long as it did is that it's pretty hard to stabilize a 30-ton crane that's essentially pivoting on the boom. And the fact that we were already working at a 30 to 40 degree slope became somewhat hazardous. Lastly, we did have an unstable crane. Our initial attempts to extricate the individual included some basic lifting techniques, and unfortunately the crane moved about 6 inches towards the river, which caused all efforts to stop until we could identify a way in which to secure the crane from moving further towards the river and potentially taking our victim. It also obviously points out that there's only one way to access the victim, that nobody in their right mind is going to access them from the riverside. You had to access them from the dam side of the incident. So patient access issues became important. As we all know, incidents like this bring out everybody. On the fire side, more than half of the Rochester Fire Department, so that's about, we had about 80 fire personnel from the Rochester Fire Department that were there. We had 2 of the surrounding county agencies that were brought in because of some of their heavy extrication equipment, specifically the use of some grip hoists, and the County Fire Bureau. From an EMS presence, we had our contract ambulance service in the city, which is Rural Metro, myself, and unfortunately this is a fatal incident eventually, and so the ME's office was involved. Law enforcement, construction workers, media, civilians, so there were a boatload of people. And one thing that was done extraordinarily poorly with this is that we have actually no idea in terms of accountability how many people were at this incident. That was clearly one of the flaws of incident management at this incident, and you'll understand why that might be important here in a bit. So from a fellow perspective, and really for all of us as EMS physicians, we really have to remember that we really need to make sure that we participate in the accountability process. And so whether you have accountability tags or other measures, make sure that you are part of that and that it's happening. I certainly find myself reminding command officers on a unfortunately somewhat regular basis who's taking accountability, and how do I make sure that my wife can find my remains later on that I really was at this incident. The other thing that I think we all notice as EMS physicians is that we all very often also play the role of a safety officer. Maybe not specifically regarding the fire attack or the extrication, but really thinking about the medical needs and the medical risks to the rest of the responding crew. And in this case, yes, there was a safety officer, but really nobody was ever thinking about the risks to the rest of the responders. And even I didn't do a very good job at that because I was focused on the victim, which gets to one of our teaching points a little bit later on that I'll share as well. And when in reality, this was the perfect scene to control access. This is the only way to get in and out of the accident scene was through this man ladder. So you had a perfect setup to control access. However, we didn't. The other challenge that we had is from that parking area that you remember on the initial map, that it was quite a ways. It was about 100 yards from the parking area, almost a quarter of a mile from where all of the apparatus was staging during this incident. And so that became a challenge in terms of moving stuff. In this incident, we had a number of companies that were detailed just to move cribbing and heavy rescue equipment, and therefore exerting themselves during this time. We had a single a truck company whose sole responsibility was to be the elevator and to bring things up and down in terms of all of the equipment that we needed. This also plays into our understanding as to how long is it going to take to get this patient from definitive care once we get him out from underneath this crane. And so a very safe estimate was it would probably take us about 15 to 20 minutes from the time that he was extricated from the crane to being in the back of the ambulance and moving down the road, given the incident site and the hazards that we have there. And that becomes really important when we get into rescue and recovery determinations a little bit later on. You know, the other thing that I did not do very well with this is that I don't have a fellow, I don't have a huge cadre of docs, and I didn't bring any reinforcements. And this was a really long incident. And as I mentioned, there were certain clearly needs for the victim, but there were also needs for the responders. And bringing reinforcements, meaning other docs, is really, really important. That nobody should really go to an incident this big alone, because I certainly got tunnel vision in this, and it's important that you have other folks that can do it. The other hazard is that there's only about 3 of us that operate our response vehicle, and we're the only ones that know where the stuff is in the vehicle. And so what we've done since then, and again, this is 4 or 5 years ago, is number one, making sure that we clearly label all of our bags and what the purpose of those bags are. You know, for example, the ALS bag, the airway bag, the crush bag, the tox bag, etc. And then what I've also done is I've made sure that we've familiarized, you know, some of our key personnel in the different departments, so that they know what's in the vehicle and therefore how to access it. Because once I made patient contact, I wasn't really excited about leaving the patient to trek up in another quarter mile to get more gear out of my truck. Instead, I can have, for example, one of our EMS supervisors be able to get the equipment out of the vehicle, or one of our EMS officers from the fire department be able to do the same. So again, familiarize some key personnel with your vehicle, what's in it, where it is, so that they can get it for you if you are actually, you know, well knee deep into an incident. And then scene control is huge, because as I mentioned before, this is a relatively high risk environment, and you look at what utter chaos this is, right? So this is relatively early on in the incident. You see our victim down here, who again is conscious and talking. We have a couple of firemen attending to him. We have a guy leaning over the edge over here that doesn't have a PFD on. You got all sorts of, right, lots of people, very, very uncontrolled scene. And it took a while, but eventually we were able to control that scene. And once, and unfortunately this was literally probably an hour and a half into it, really identify who does and who does not need to be in these environments, because we all know how chaotic it gets in our emergency departments when a trauma or a cardiac arrest comes in and everybody and their mother wants to be in there, and it's very difficult to control the environment and provide good care. Same thing is the case here. And so everybody in this picture had a very, very clearly defined task. And so as we kind of zoom up in here, here, you know, these three individuals with the green circles were really our command staff. The gentleman in the task force 2 shirt was our technical rescue expert slash consultant. The battalion chief here in the white was really the operations supervisor. This gentleman, this is one of the lieutenants who is responsible for extrication. These 4 gentlemen were all responsible for actually facilitating the extrication using hydraulic tools and so forth. This was the medical team, so myself, one of the Rural Metro supervisors, and one of the Rochester firemen who essentially became my monitor and vital signs the entire time. These 2 individuals, and this is something that we often forget about, the 2 people with the purple circles around their head, their sole responsibility was to extract the patient once we got him out. So their role was not to get bound up in tool extrication or safety or anything else, but once the victim was pulled out of this environment, to get him on the backboard and hightail him up to where the Stokes was to extract them out of there. And then lastly, these 2 individuals, as you can see, we just use simple jacks on both sides of this crane to help lift the crane up, and their role was, of course, to keep an eye on that jack and yell really loud if something is moving in a direction that we didn't want it to. So again, scene control becomes really important. But let's go back to our patient care goals, right? So we have a gentleman that's stuck underneath a crane. First thing that we want to do, obviously, is assess injuries and monitor closely. And I don't know about some of my colleagues that are on the call right now, but generally, when I have incidents like this, I'm not terribly interested in monitors and life packs and all of that stuff. What I prefer is one human being to make and maintain contact with that victim the entire time, and be able to obviously get a set of vitals, but really just monitor their mental status. And in this case, we had a 63-year-old male with a history of hypertension and really no other medical problems, who remembers everything that happened, that he was operating the crane and then it flipped. He feels like obviously he was partially ejected from it. He cannot move by virtue of being entrapped, not because of paralysis. And he is able to breathe and talk. He is having some respiratory difficulty. He's mildly tachycardic at about 105, 108 beats per minute. His manual blood pressure, we did get 1 before his position moved such that we couldn't access him anymore. And his blood pressure was in the 130s or so. And he was an unbelievably cooperative patient. He was unbelievably patient in terms of time, and was trying to help us identify ways to be able to remove him from this. So quite quickly, the plan was to use one of our firemen who had made the initial patient contact, who was really going to be the eyes and ears and monitor him constantly, and that was his role really for the next almost 3.5 hours. Our other care goals, as I think we all know, for prolonged entrapments, is controlling temperature and mitigating crush. We'll talk about that in a second, and then really how are we going to facilitate all of that. So this is really one of the first pictures of him right after folks got there, and you see a fair amount of his body is exposed. On the upper right-hand corner, you see some orange stuff. That was the cab of the crane, and his feet were pulled up underneath there, but to the extent of entrapment, we were not quite clear. Again, he's able to answer questions. He is able to follow commands and so forth. And so firefighter Faulkner here is, again, maintaining contact, and he was with him that entire time. So he was my Life Pack 15 or my Zoll or my Phillips or whichever one you want to use today for this incident. Now, the next goal, right, is thinking about, okay, how can we maintain his temperature? Now, right now, on that day, it was a very, very nice day. It was in the mid 80s. It was sunny. It wasn't too big an issue, but I just want to remind everybody that even really there's only 1 or 2 days in upstate New York where you don't need to worry about temperature regulation, because really anything that's less than 98.6 means that they're going to start losing their body heat and temperature, and we know that that's all bad. So just as a quick reminder, there are some both intrinsic and treatment-related things that we do that often worsen traumatic hypothermia. Right? We know that with increased age, or really the extremes of age, alcohol intoxication and injury severity, all of those are directly correlated with decreases in body temperature. And then certainly the things that we do, whether it's fluid or blood product administration, treatment exposure, and so forth. And we also know that there's all sorts of really bad things, and I'm not going to go through all these given the audience that we have today, but I think we all know that traumatic hypothermia is a real thing, and it affects just about every organ system that we have to deal with. And so we have really this fundamental triad that we always have to remember in terms of hypothermia, acidosis, and coagulopathy. And there's a handful of studies that all very clearly demonstrate that hypothermia is associated with an increased mortality, and that definition of hypothermia is much different than what we consider environmental hypothermia. Right? Most of us are thinking a cold exposure, it's less than 95, when in fact really anything less than 96.8 is considered traumatic hypothermia. So that becomes really important. That's something that, quite frankly, we did not do a very good job at during this incident, was trying to maintain his body temperature. And this is just a picture that kind of reminds me of the extremes. And these are men and women serving us in Iraq a number of years ago. And that is a live human being that is in the body bag, because that, for those of you that have done military service, thank you, but that was not uncommon in order to maintain body temperature, is to place our injured in a body bag, put a bunch of heating devices in there to maintain their body temperature. And obviously everybody in this picture is breaking a sweat, so it just goes to show us how important this is, and how our military colleagues have, like many things, gotten it right. So back to our victim, right? So call me crazy, but I figured maybe a 30-ton crane on top of somebody might cause some crush problems. And so, we have to remember about crush syndrome and really all the different effects that it had. And I think we all know really our management for that is going to be fluid administration, right? Because we have shock, all of our metabolic things that occur associated with this. And we all know that we really have to have a high index of suspicion in the field. Obviously, we're not getting CKs in the field, and it's kind of useless. You have to have a good clinical suspicion for it, and really there's not a ton of harm in initiating therapy relatively early, because either you have somebody that dies right away or in weeks generally. And the way that this incident carries out, I think you'll be able to understand why this patient had crush syndrome being associated with his ultimate death. So our medical management, again, I'm not going to go too much into, because I think this is all bread and butter for us, but just keep in mind that we need to have aggressive fluid administration. My personal approach is hydrate the heck out of them with abnormal saline before moving to bicarb, which does pose some problems when you have somebody that's trapped for 4 hours, because they're going to have to pee at some point in time. So you have to think about that as well. Certainly there are a lot of other management considerations. We won't go into those today. Some of us may do a little bit of a bolus of bicarb. Some of us may do some preemptive tourniquet application, all of which may have a role in certain circumstances. But in this case, as you'll find, none of these were really options. Because the first period of time for this, you saw the initial picture earlier, our victim had his arm out, which was just begging for a nice big 14-gauge IV, right? And about 30 minutes into the extrication, and about the time that I got there, is when they did the first lift of the crane to see if they could pull him out. That's when the crane went towards the river about 6 inches, and the patient screamed, and everybody screamed, and everybody stopped. But what that did is that it actually did move up the crane just enough so that it was more comfortable for our victim to move towards the riverside and turn his shoulder in such that all of his extremities were facing towards the river. And the only thing that was facing towards us was his back and his head and his left butt. And so we lost our golden opportunity to gain vascular access, which is really a hallmark of any type of prolonged entrapment. There was physically no way to access an extremity or even the neck, given his position. Again, this was relatively early, the picture that you see right here, but you know, the takeaway that I continue to emphasize to my paramedics as well is, you know, listen, if you have somebody that is heavily entrapped, really, as soon as you can, please just at least get a lock in them, get some form of access, because in this case, we had a golden opportunity. We lost it because extrication kind of went before medical management, and then the patient very volitionally wanted to move to a position that was more comfortable for him, that was not ideal for us, and he couldn't get back out of that position. So then we start thinking about facilitated extrication. I know you guys had a chat about this earlier this year on EMS Medicine Live, so we won't again go through this too much. But you know, is that an option for this guy? Well, obviously, it could be, right? We could give him an IM injection of something to facilitate his extrication. But he's still conscious. He's still oriented to his surroundings. He's uncomfortable, but he actually did not want any pain medications. I offered him a number of times some intramuscular pain medications, and he did not want it. But one of the things we have to think about with facilitated extrication is that I personally will never use this unless I know that I'm going to be able to get them out, right? And I have means to access his head, maintain his airway, and so forth. And it was pretty clear in this case that I may not have that ability to be able to do that, given his positioning in the vehicle, underneath the crane. So we can remember our indications. We need to think about how we may use it, but certainly preparation for any type of facilitated extrication is absolutely critical. They need to be medically optimized. Obviously, I'd love to have capnography and cardiac monitoring and so forth, and the ability to manage their airway, but in this case, many of those things were not possible. And therefore, obviously, we did not have that as an option. And lastly, you know, certainly I can only speak for some of our upstate folks, but maybe it's better in some other places. But making sure that the medical and the rescue teams are on the same page is sometimes a challenge, and we need to make sure that everybody is on the same page, because as we noticed early on in this incident, we did not have the opportunity to get in there and at least get vascular access on him before they started an extrication, which then caused us to lose that opportunity for vascular access later on. And so that really comes back to the docs educating all the parties as to why that's important and why you need to let us in there to be able to get that initial assessment and perhaps an initial intervention so that we have it a little bit later on. So in terms of, again, facilitated extrication, really this is most of what I mentioned earlier in terms of analgesic sedation and removal and making sure that everybody pays attention. That again was covered very, very well earlier this year. So let's go kind of back to our patient, right? So we have this older gentleman who's stuck underneath the crane. Our initial assessment is that he certainly has the potential for significant crush injuries, as well as my concern for pelvic and or other rib fractures. The other concern was his legs, in that he could not move his legs very well because of entrapment, not because of of paralysis, but we could not identify very well how entangled his feet were underneath the crane. We actually used confined space cameras and other things to try to get a good visual, but it was very, very difficult because of how far underneath his feet were and how difficult it was to access that. So it took literally about 3 hours, almost 3 hours and 20 minutes from the time of the initial incident to effectively stabilize this, utilizing extraordinarily heavy rigging and so forth, so that when we lifted up the crane to extract the victim, that he did not, and the crane did not go into the river. So throughout that entire time, we are making constant reassessments with him, but frustratingly not able to gain any type of vascular access or be able to deliver really any type of treatment during that time. And so, as you remember from the initial incident log, it was about I think it was about 2:30, 2:35 in the afternoon that this call happened. This picture is taken a few minutes after 6, when about 6 p.m. we were able to have everything situated enough that we could elevate the crane, and we did. We lifted up the crane about 2 inches. Which was enough to pull our patient out from underneath, only to recognize that his feet were indeed completely encased in the cab that remained of the crane. So our thought was that he was ejected and his feet were on the concrete with the cab above it, but in fact that was not the case. His foot was completely trapped into that. And so we pulled him out. We started gaining IV access. I am in the tan gear here. You can see part of his jeans there, you know, I think all of us have taken care of patients over our careers where we know what's about to happen, and that god-awful pit in our stomach comes out, and this was certainly the case for me, because the lieutenant called me over and said, "Doc, we got a problem." And sure enough, now that he was elevated enough, you could get your hands in there and realize that his entire foot and ankle was completely encased in metal. In that he was not, the rest of his body was not coming out except with torches or a field amputation. So while that is happening, and again, that is kind of his legs caught up in there. The thought of field amputation comes into play, right? So again, I'm pretty sure you've had a chat on this as well, in that really, right, our goal is to just free the limb and free the casualty. It's not definitive. And, you know, in this case, we've certainly exhausted most of our other methods, and our victim at this point in time very rapidly started to decompensate. In an ideal world, our field amputation, we're optimizing that patient, and we're performing that amputation as distal as possible. I think all of us have probably been called out to amputation requests only to find that their entire torso is in whatever the device. And I don't know about you guys, but hemicorpectomies are not in my skill set. So so a lot of that is also just kind of educating our providers. This is the very simplistic kit that I keep in our vehicle. We simply use a giggly saw and handles. We practice it on a regular basis. Remember applying our tourniquet, making as close to circumferential incision. Removing as much tissue as you can, applying your giggly saw and simply cutting. This is one way to do it. There are also other saws out there, and then of course there's also a Sawzall on every rescue truck, which unfortunately is what I used in this case. But our field amputation gets completed and gets appropriately dressed and so forth. So that has to go through your mind, right? So am I about to do a field amputation on this guy? And literally, as that is going through my mind, the paramedic that was mitigating him is telling me, Jeremy, that his color just went to crap, and he's not really effectively breathing. He's unconscious now, right? So very, very rapidly, literally within about 8 to 9 minutes from the time that it was even less than that. It was about 4.5 minutes from the time that the crane was lifted to his physical decompensation. That's all it took. His color became ashen. He became obtunded, and again, he was conscious the entire time. At that point in time, we had vascular access because we had pulled him out of his torso, at least out. And now you have a decision of, okay, do I manage the patient or do I do the field amputation? Keep in mind that at this point in time, he is still prone. So that makes airway management a little bit more challenging, although I was able to intubate him. We got him on the monitor. He's got a wide complex tachycardia, no doubt because of his hyperkalemia. Started with some calcium and then very quickly lost pulses. And so he decompensated extraordinarily quickly. And now's the part that none of us really like, but that I think all of us have to be prepared for as EMS physicians, is making the call, right? So all these guys, and you can see their body language as I'm telling them we're done, essentially, that we have to think about our rescue and recovery considerations, right? So in this case, I have somebody that I cannot even do effective CPR on. It's still going to take me on a good day quite a few minutes to amputate his extremity for what is likely a terminal condition anyway, right? Not to mention that I already said that it's going to take probably a good 20 minutes to package him up, get him lifted up into an ambulance, and then another 10 to 12 minutes to definitive care. So we know what the data is for essentially blunt traumatic arrest in the field, and we have to be prepared for that. And I'll be honest, I didn't think about it. I thought about managing crush. I thought about managing facilitated extrication. I thought about doing a field amputation. I didn't think about when would I stop everything. When would I say, guys, we're done? And I think that's one of those things that we all have to consider, because there's a tremendous amount of risk associated with this evolution, right? The river is already bursting at its seams because it's been 3.5 hours that we've held flow back. We have a crane that's being held up by 2 wires, which always makes me a little nervous. And we have about 14 other folks, myself included, that are not in a very comfortable place in terms of a safe work environment. That compared to the benefit of trying to transport a blunt trauma arrest, because that's really what this is. So I think we all have to keep that in the back of our mind, and I've gotten a little bit more proactive in terms of making sure that particularly the extrication team is familiar that if we're dealing with a blunt trauma patient and he arrests, more often than not, we're going to stop everything right there, because it's not worth the risk associated with it. So all of those things I think you need to kind of put in mind. And then all the stuff that happens after the incident, and this is the part that I think as EMS physicians and certainly as an EMS fellow, I never really had any exposure to. But I think it's important that I share this, because I think it's one of those things that we don't talk about that we should. Is what do we do after the incident? And you kind of start looking at the body language after this was called. Remember, we're still in the fishbowl, right? Everybody is watching. All of his coworkers are watching us pull him out and yell and be really happy and excited, and then all of a sudden chaos, and then all of a sudden somebody's putting a blanket over him. So you have almost 100 responders and even more folks that are all in that environment, and you look at folks' body language, and everybody's just kind of completely drained, completely wiped, completely out of it. And really, what do we do after this? What do we do as an individual physician? What do we do for our companies? And this is still a difficult incident for me to think about, and particularly for many of our fire colleagues. They're not used to being with a patient for 3.5 hours and talking to him for 3.5 hours, to them have him die in front of you. And so, one, we need to know either from a physician or from a fire department or EMS agency perspective what our stress management resources are. Allow our personnel the time they need to diffuse. The decision by the command leadership was, we were almost 2 hours past shift change. So you know what that meant, right? That meant that everybody that was on this incident were said, okay, pick up, grab your gear, get in the buses. You're going to get taken back to station. They'll debrief you there, and we're going to get the oncoming companies to help do the pickup. And that was devastating for a lot of our firemen, because they wanted to finish the job, because at this point he still wasn't extricated. He was dead, but he was stuck in there. And that was really, really difficult for the fire guys. I spent pretty much the entire next day with all of the companies involved, really just at the coffee table, which, as we all know, particularly in the fire service, that's where everything really does happen. And it was really important because so many of them, I certainly understood what happened from a physiologic perspective, right? I mean, this guy had both significant internal bleeding that was being tamponaded by the fact that there was a crane on his pelvis. He had multiple pelvic fractures, multiple rib fractures, and then he had significant hyperkalemia that was released as a result of his crush syndrome. So he had kind of both as his cause of death. But the fire and EMS folks really didn't know that was the case. And so being able to educate them and really get them to appreciate that he was, in many respects, dead when we got there. It's just that it took 3 hours for us to realize that became important. And then also as physicians, I think, particularly as EMS docs, some of us might work in relatively isolated places, or don't have as robust a team as some of the places that I'm talking to right now, where you as a responder need to talk through these things, because it's difficult, and you second guess yourself a lot, and it's always helpful to be able to go through that. The other thing that I was completely unprepared for was this. And this is extracted directly out of the obituary for Doug. Doug Fitzmaurice was our patient, who was unbelievably gracious to the fire service. And they reached out to me through the fire department and wanted to know in excruciating detail his last 3 hours on this earth. And I had never quite been put into that position before, to the point that the fire chief and I, at the family's request, even went to the funeral. And the family was unbelievably gracious for everything that we did. But really, as a physician, you kind of end up taking that leadership role. And one thing that I certainly regret, and I know is done in some other systems. I know FIDNY does this a lot more than for folks getting stuck in the subway and whatnot. But I certainly do regret not trying to make some sort of communication between our victim and the family. The environment was probably too unsafe to get the wife down there or otherwise, but certainly a phone could have been done for an incident of this duration. And then be prepared to candidly speak with the family. I think we do this certainly in the emergency department, but it's a little different when we're in the field. And in this case, they wanted to know an awful lot. And certainly, some of us may have gone to our patients' funerals, but it was a very surreal experience. But I will tell you, it was also unbelievably healing. Both, I think, for the family as well as for myself as an individual. Just the unbelievable outpouring of love and support. So much of us do this job in such a thankless manner that to have the support from the family was pretty unique. So, in trying to keep this short, right? There was a lot of learning that happened here, and so a couple of things to keep in mind. Certainly, be safe. Think about accountability. Think about gear sets. Think about who can access your equipment out of your vehicle. Certainly, don't underestimate that the mechanism. Use your clinical assessment. Remember that all of our traumas are cold, and we really should be at the least passively warming them. Anticipate and aggressively manage that crush syndrome. This had that written all over it, and we missed our golden opportunity to gain vascular access, which in the end would not have made a difference, but I really don't care. I certainly would have felt a lot better about that. That is also why we did not have blood products at the scene, because I didn't have any way to get it to them. I thought cut downs, all sorts of different things, but as we think about the anatomy, there's not too much on the posterior side of the body that we can access. Always consider these indications, risks, and benefits of both field extrication and field amputation. In this case, once everything kind of settled down, we got the medical examiner out there and so forth. We did perform a post-mortem field amputation, which again was not done with any grace. It was done with a Sawzall and a fresh blade, which is quite frankly the easiest way to do it in these environments. Eventually the foot was recovered when the crane was brought topside 4 days later, and brought with the rest of the family, which is also a little difficult to explain to the family that not all of the body was there yet. And then lastly, really please take care of the family. The family meaning our fire and EMS family. And the team that you operate with, and please don't forget about yourself. I think we've all had difficult incidents over our careers, and will. I hope to God I never have another incident like this, because it was certainly a once in a career incident, but lots of stuff to learn. I hope me sharing this with you helps you think about some of these things, puts them in the back of your head for the next time you roll up on something that looks a little odd. And I'd be happy to take any questions or conversations at this point. So, all you, Christian.
All right, I'm gonna unmute everyone here, I think. So if you have any questions from peanut gallery, any comments?
Rural Metro notify the OIG of certain events.
That's Brian Clemency here in Rural Metro.
Yeah, who's watching the Rural Metro trainings?
Gotcha. I'm glad you shared this with us. I thought it was useful in the 20-minute version, even better for the hour version, to see kind of the start to finish as a good example for EMS physicians and kind of lessons learned. I'm looking at how would you passively warm him. I'm not even sure. You couldn't get to him with blankets or heating pads or hot fans or anything to try, but that would have been frustrating. We've had the same problem here with the trapped patients, but in the January, February, middle of the night times when it's freezing cold, and we're having problems getting to them as well. I think the only thing I would add is when we have events with my firefighters, I always caution them with alcohol. I'm not sure what other folks do after these type of events. When I was in the military and now with my firefighters, it's not uncommon for them to go drinking after something bad happens. And
Yep.
I would just remind folks to remind their folks to not do that. It's common.
Absolutely.
It is brings people together, but it's just adding the alcohol to that, I think, doesn't help people learn to cope or work through what they've gone through. And that's hard to overcome sometimes, but adding that voice of don't do this tonight, I think it's been helpful for my guys in the past.
Yes.
So
Absolutely.
Jeremy, did you do the postmortem amputation, or did the medical examiner?
Yes. Yeah, that was a group effort between the medical examiner and myself.
Okay. I was thinking that must have been difficult as well. Seemed like that would have been difficult to do. Let's just put it that way.
Yeah, it was a little surreal, and certainly it's a little easier to do when it's not terribly messy, and so forth. But we had to be very. I mean, again, that was very, very methodical in terms of how that was done from an investigatory perspective. Taking photos before and during and after and whatnot, just to document all of that stuff. But again, I'm certainly not advocating that all the EMS physician vehicles carry a Sawzall, but it is one of those things to remember. It is a resource. It's probably a little bit more appropriate than a no cutter, but still, in this case, it was probably the best tool for the job, given how far in and under he was. So.
It's kind of a personal question, but looking back on it, would you have preferred if one of your partners came out to do that part? Or did you find it more you wanted to see it through? And that was kind of hard?
No. I think I was fine with doing it, not necessarily having one of my other partners. I think one of the things that I mentioned earlier on is that I really should have made better efforts to get another doc out there. Mm-hmm. For two things. One, to just be able to bounce something off of folks, because I'm racking my brain trying to think of what else could we do in terms of vascular access or whatnot, but to be able to, say, hey, take a look at it, any other ideas I think would help. And as I mentioned before, so often I think the EMS physician ends up being if you will, responsible for the health and safety of everybody else, even though that's really the safety officer's job. And that was completely ignored through all this. Yes, we did have water down there, yes, but still, we probably could have done a better job with all of that. So having some level of redundancy, I think, is one of those things that I kind of got in the zone, and I never. Yeah. I was to some extent ignorant at that point in time, and that's something that I have not made the same mistake of since on a couple of, certainly nothing to this scope, but a couple of other incidents in the last few years.
Fair enough. Any other questions from the group or comments? All right.
Well, thanks everybody. Thank you, Christian, and good luck to all. Back to you.
I would just remind folks one thing. For next month, we may move it to Wednesday instead of Tuesday. Mike Millen from Johns Hopkins is going to do backboards in EMS with all the changes we've been doing across the country. And he's very passionate on this topic, but he can't do Tuesday. So we may move it to Wednesday. We'll let you know. We have Mike Daly coming up in November, and we'll be looking for someone for December right before Christmas. Merry Christmas. Got to make a presentation, but find something. Otherwise, thanks so much, and we will see you all back next month.